Good morning. My name is Angela Brown, and I'm going to tell you a little bit about the things we learned from doing enrollment with our program called Gateway to Better Health. For those of you who are not familiar with this program, it is a program for people who live in St. Louis City and St. Louis County. It was started July 1st of 2012. The program provides primary, specialty, and urgent care coverage to people who are uninsured between the ages of 19 and 64. The goal of the program was to provide a bridge for our safety net population until health coverage options were available through healthcare reform in Missouri. So again, a part of our target population were those people under 133% of the federal poverty level. So this would have been a population that would have been available for Medicaid expansion had it been expanded in Missouri. Through this program, we have been successful at enrolling more than 25,000 people in the program. And so that was something we were pretty much proud of through this program and with our community providers. A little bit about how we did our application process. Because this is a federal waiver, we partnered a lot with the states. Working with Family Support Division, we were able to develop an application very similar to what you guys have seen with Medicaid. We did have requirements for verification documents, looking at income, residency, and citizenship, which is hopefully this is pretty specific to Gateway, because looking at Medicaid reform and your enrollment with people onto the marketplaces, they will have different databases that FSD can use instead of having to provide those paper documents that we had to go through that did present itself to be a barrier for enrollment. We also had an online tracking portal for tracking and reporting on the outcomes of where we were at collecting applications, which was good for keeping up on sort of our successes in with enrollment. One of the things that we did here was training. So FSD did a lot of training around the application, how to complete that. With our online system, our staff actually went into the health centers and actually did a lot of that training. I think one of the things that we learned that we didn't particularly or were surprised about was that basic computer skills. A lot of health centers did hire the temporary staff and some of their staff that we did a lot of training around sort of how do you upload attachments, different things like a lot of assistance with passwords and different things like that that we were not necessarily expecting. So as you're thinking about training staff, one of the things you might want to think about is just sort of basic computer skills that we take for granted that people already have a lot of experience with. With our enrollment, the actual enrollment process actually took place at the different health centers. It started November 2011, so there was a good period to start collecting applications before benefits actually started July 1st of 2012. And then as part of that process, the health centers actually collected applications. We did have a paper process for this, so an online system or different options would be a lot easier to maintain, and we had to have those paper applications actually delivered to FSD. So again, there was a lot of tracking issues with that and communication process that we had to work through for that. And then again, FSD sort of determines our gateway eligibility. One of the things that we did learn from this is that being able to decentralize the outreach and enrollment process to keep it in the community with community health centers was a great asset for this program, because patients, a lot of these patients that we encountered were in and out of the state system, so they have food stamps, they've been on and off Medicaid, and if you all have ever experienced a letter from Family Support Division, you know how confusing they are. And having that community support, someone who works with them, have a trusting relationship with them, to be able to assist and help with that extra communication proved to be a valuable asset for our population. And so just not sort of the Regional Health Commission taking on that outreach and enrollment, but giving it off to the health centers was something that we really saw as an asset for enrollment. Another thing that we found with our health centers was that you have to be persistent with the outreach. So for health centers who were able to enroll a lot of people who were successful at their enrollment, they did a lot of different things, like they had enrollment fairs. They went out to homeless centers. They did door-to-door. They did phone calls, mailings. Also even went to unemployment offices where they can actually reach this population, places where the population actually were, instead of having them always come to them. Even one health center actually provided food, so they did luncheons for people to come and actually eat. So those things kind of proved to be very beneficial to helping us get that enrollment numbers. For people who even did external enrollment, we also had people to use billboards and bus signs, which also proved to be another asset for helping people get enrolled in the program. And then sort of the last thing I want to touch on about what we learned with Gateway to Better Health is being able to communicate the urgency. So again, our program, we started enrolling in November, but benefits didn't start to July. So really complete, like, you don't have until July when the benefit starts to enroll, but trying to have that sense of urgency around this population so that they apply while the enrollment periods are open. And also to the people who are young and healthy. We found that people who were sick or who had more chronic illnesses who needed the insurance or coverage program were more likely to apply early. And those people who, you come once a year who are healthy, the younger population, it was harder to get them to apply in a timely manner. So having some of those talking points and being able to commute the urgency around applying for the marketplaces is something else that we found with our program. And I think that was pretty much sort of what we learned from the Gateway to Better Health program to share with you today. Thanks.
We'll open it up for questions after we have the three panelists. So I'm going to invite Carol to come up next.
Good morning. I work for a program that has 300 volunteers and about over 160 community partners to help people navigate Medicare, which is insurance for people who are 65 and older, and for some folks who have a disability, they can have this insurance, this private insurance. Well, Medicare is a very complicated program, and so we train our volunteers to help them know how to enroll, how to obtain their benefits, if they have a claim problem, how just to navigate that world. Well, the last program that was probably a major change for us was when 2006, when the Medicare Part D program came into place. It was the most major change in the Medicare program since Harry Truman signed the first Medicare card in 1965. And the opportunity to speak today kind of made me have an opportunity to go back down memory lane to see what it was like to implement a brand new program in the nation. We had many people who thought this should have been piloted. This should have been a regional program before we went nationwide. Because if you remember correctly, that program started and we just went forward nationwide. Plans were considered often hard to understand with all the nuances. Today, they still have their nuances, but we're a little bit better prepared and understand the plans quite a bit more. There was lots of attention from the White House to the media. We had lots of visitors to our state of Missouri. People didn't understand the donut hole, the penalty, or the benefits for extra help. And these are issues that we still work on today to help educate and increase awareness on that. And there was this learning curve of doing comparisons on a website and how to effectively use that site. And I know that that's, for some of us, kind of an area that, how is that website going to use? How are we going to navigate it? How are we going to understand those plans? And people wanted the program, but didn't understand the cost of the program. So I think some of those common ideas are some of the things that we're worried about implementing the ACA program. So I have some highlights. It's kind of the cheerleader approach of that we can do this. I hope that's how you will take that. But I'd like to encourage you to really be sure that you understand the purpose of your program. Why is your agency taking this project on? Why are you doing this? And how does that fit into your overall mission of your program? And what are the goals that you really are trying to achieve? That is really helpful to help you stay focused on what you're wanting to do and not get sidetracked with all the other noise that may be around the project. Be prepared. To me, the most important thing for our program is to have volunteers who are well trained. Training is so important, not just the online training that we will have available through CMS, but you need to practice. We train volunteers, and then the first time they go visit with someone, it's like, okay, I know that, but how do I help them? People really need to practice, have practice scenarios. Your CACs need to work together, write up some scenarios. How would they work on this situation? How would they talk with that person? Practice eases a person's concern when they're wanting to help people. So practice really makes it more of a natural discussion and a better understanding. As a group, we really need to share our resource and tip sheets and discuss actual situations together, learn from each other. Many of our counselors, we have a training manual, but many of them have their tip sheets down to about 3 or 4 that they can use. So they're quick guides for those questions. Like, for one, I can never remember numbers anymore, so I have to always have the income guidelines with me, just because they just cloud up my mind and I'm not a number rememberer. So I always have my income guidelines or money tip sheets. Those things help you feel at ease when you're helping someone that you're not guessing. Be sure that all of your counselors have the tools they need to do the job. Our enrollment toolbox gets bigger and better every year. We add materials, we delete materials that are not needed. I will say, though, technology is often the most difficult. Do not assume everybody knows how to sign on to a wireless network. We've been in buildings where they said, oh yes, we have wireless. Wireless worked at one end of the building, didn't work at the other end of the room. So be sure you check your technology, because that probably is the #1 problem that you can have. The internet could go down unplanned. Focus on education and awareness when you're working with people to help people make informed decisions. People will want you to make that decision for you. People will say to us, what would you do for your mother? What would you do for your father? They will be asking, what would you do for your family? That's an opportunity to ask them more questions so they can make the best decision for their family. Those questions help people make a good decision for themselves. You may know or believe you know what the right answer is, but you want to make sure that they have made that decision. Expect the unexpected. Your agency internet will go down just as you're doing helping a person enroll. The CMS site might be overloaded. I remember the time when CMS had to, I don't know the right technology, but enlarge their bandwidth because so many people were on the website, it actually went down. Your lobby is full. This would be a good problem, and the phone's ringing off the hook. What are you going to do that day? You may get a thank you note from a person who was so difficult that you thought they would never come see you again, but they sent you a thank you note saying how much you helped them. Take a deep breath and don't panic. That's what Jeremy says that I tell him to do. Take a deep breath and don't panic, and really keep a positive attitude. Troubleshoot. Remember to look at problems as a way to do things better. We will encounter issues that we don't know the answers to, or something's just not working quite right within your facility. It's an opportunity to make something better. Not a problem. And build up what you already know. All of you are doing community-based work. You know these principles. So take what you know and use it and build upon it. You know that it will work. I think this is very important. Don't be afraid to say, I don't know, but I will find out. People will have questions that we will not know the answers to. But it's better to say you don't know and that you will follow up and get back with them. It does 2 things. It brings trust for your client. It gives you an opportunity to build your own knowledge, because if that person has that question, another person will too. And it's not necessary to know all the answers, but it is important to know where to find those answers. And it amazes me because people will call us and say, well, I've talked to so-and-so and talked to so-and-so, and then, you're able to help them. It's because you have heard that situation so many times that you know the right question to ask. They think you're a miracle worker, so that's a great thing. Application counselors will become experienced, and they will know those questions. Gather your stories. This is so important. It's something I don't believe that our program works on enough. People, the real life situations make numbers look real. And the stories that are behind those numbers are really what's important. Numbers are very important, but the stories are even more important. Our stories help affect future policies and regulations. I believe our stories about open enrollment timeframe was a reason for the policy change from October 15th to December 31st was changed to October 15th to December 7th. I'm sorry, it was November 15th to December 31st. Also, we've seen the donut hole closing over the next few years because of the stories that we've been able to share. Collaborate. Our program would not be successful as a claim program if we did not collaborate with people. And collaborate in the true sense. We have to share our resources, our knowledge, and our skills. This will help maximize our efforts. We cannot do this alone. We need to work with each other. There may be a sense that we might be tripping all over one another in our efforts. And so this is why it's really important that we share information with our hubs so we know that who's going where, who's doing what, so we can make sure that our efforts are well utilized and that we're covering every group of population that we want to cover. So collaboration is key to that success. Let your community know that you're doing this work. This will provide them an opportunity for you to come to them, and it also will let them know that your doors is open to help their folks. So spread the word. Collaborate's probably number one key success, along with many other things, to help us be successful. And I think Cover Missouri will help us do that. Reach out. If you have questions, I can almost guarantee you that someone else has the same question. So be brave and just ask it, because there are no stupid questions in this world. So just ask the question. Collect information. I know that reporting is so hard sometimes, but it is important to collect information, not only for our project, but for your own internal work. We know from our work that in our SHIP program that we still need to do a lot more work in the rural areas. We know that by the data that we've collected. How do you refocus some of your outreach efforts if you don't know if what you've done is successful? So it's important to collect data and to read the data for and how it can help you. Probably, though, the most important thing is to celebrate your successes. You can never say thank you too much. You can never send too many thank you notes. A box of cookies will go a long ways in helping people feel good about what they do. One of the things that we do is share our successes at staff meetings. Just tell a good story. Be mindful about what you do and how you're helping others. Thank you.
Thank you, Carol. I'd like to introduce Joanne, and I'm going to get her slides up.
Okay, good morning. I'm Joanne Morrow from Legal Services of Eastern Missouri, and I hope you're all familiar with your local legal aid office. We provide civil services to low-income people, and there's a legal aid office that covers all of the counties in Missouri. We're in the eastern region for legal aid. One of the programs that we work with is Medicaid. And the title of my presentation is CHIP Enrollment. CHIP stands for Children's Health Insurance Program. In Missouri, it's an extension of Medicaid. And you really can't talk about CHIP without talking about non-CHIP, all of the other Medicaid programs. And I apologize in advance if my presentation is a little disjointed, but that's my life with Medicaid, you know. Medicaid is very disjointed. It's a wonderful program. Don't ever underestimate the value of it to our citizens. But it evolved piecemeal, and the rules for one program may or may not necessarily apply to the other. So I want to pick up a little bit on what Carol was talking about. We help people navigate the Medicaid program, just like she helps people navigate the Part D program. And, you know, we originally were challenged to help people in managed care, but we also found that in the process of that, just getting them enrolled in the Medicaid program was also our job. So that's a lot of what we do. I'm going to first go through the Medicaid program in general, just to give you some basics on, where I'm going with this, and then give you some examples and show you how we kind of help people navigate the program. So I'll get to the next slide. Okay, this is managed care in Missouri, the colored sections. The western section is kind of light, and actually there's an error on this slide. The yellow is the central region, which you can probably figure out. The pink is the eastern region, that's where I work, and then this light greenish blue is the western region. The white part of the state, they are not in managed care. So, it's all along the I-70 corridor, the counties north and south of that. And for those of you who are familiar with managed care, the Medicaid population, just like a lot of people, are in big HMOs, and they're regulated by the Department of Insurance like any other HMO. They have to have a network. And in the very rural counties along the Iowa border and then down south, there just isn't the network that they can get together. So that's why you have managed care along the I-70 corridor and not in other parts of the state. There are 3 managed care plans in Missouri, and it was different in every region. Now it's all the same. There's Healthcare USA, which is soon to be an Aetna product. They formerly right now are with Coventry. They're going through that transition. Home State Health Plan, which is Centene, and Missouri Care, which used to be Aetna but is now WellCare. So these are big companies, but they also have a Medicaid project. So this is what we help people navigate through. These are 3 different, the blue little boxes, that represents the Family Support Division part of the process. The yellowish green boxes, that represents the Mo Health Net Division part of the process. And then the pink boxes represents the enrollment broker Wipro Info Crossing. So in the Medicaid program along that I-70 corridor for managed care, all 3 entities are going to be involved. They communicate, but they don't always play well together, So this is the process we navigate. It all starts in the upper left-hand corner with the application process. You have to go back and forth, with the application itself. We have to help our clients a lot of times with those questions on the application. Missouri has a very simplified application for the programs for pregnant women and children. It's only a 2-page application. The questions are pretty straightforward for someone in the business, but for someone who's totally unfamiliar with it, it's not at all understandable. So that's one place where helping the client navigate through that, like, what does this question really mean? Who's in your household? Have you dropped insurance in the last 6 months? That sort of thing. So we get them through this application process. Once they are approved for Medicaid, then it bumps over to the Mo Health Net Division. The Family Support Division determines eligibility. The Mo Health Net Division actually pays for the services, arranges for them to be enrolled in managed care versus non-managed care. And if they have to pay a monthly premium, which a lot of the families do for the children's coverage, then they also contract with the enrollment broker and get that going, and then the Mo Health Net Division handles the premium payments. So once you get the child approved through the Family Support Division, it bumps over to the Mo Health Net Division. And then if the child doesn't have to pay a premium, they are immediately enrolled, and then they're bumped over to the enrollment broker to choose a plan. If they have to pay a premium, they're bumped over to the enrollment broker to choose a plan, but their plan's not going to start until they pay the premium. So it's that sort of thing, like when is my child going to be covered? It all depends. Okay, this slide just gives you an idea of the Medicaid population in Missouri. You see the big blue section of the pie, that's children. They are the largest section of the Medicaid population in Missouri. Next largest section, that kind of magenta colored, and also the light blue, the seniors and the disabled. They are another large segment of the Medicaid population, not as large as children, but they're more expensive to cover than the children. Children are a bargain in Medicaid. Okay, the next slide. This just gives you a breakdown of the various categories for children in Mo Health Net. And I was talking earlier about CHIP and non-CHIP. Most of the children in the Medicaid program in Missouri are non-CHIP. That big magenta section, 87%, only 13% are in the CHIP program. But I anticipate that maybe with when the Affordable Act kicks in, a lot of the children who are now eligible for CHIP and not enrolled, that's going to bump up. The next slide gives you an idea of what goes into determining whether they're eligible, or to determining, whether they can be enrolled in a program. There are various requirements. There are income guidelines. And when you apply income guidelines, it all depends on the family size, and also then you have to consider who's in the family. And when you get blended families, there are a lot of questions around those issues. We help families negotiate that. It's all based on income. Okay, what kinds of income are we talking about? Because employment income is treated differently than SSI income, and that is treated differently than child support income. So those sorts of factors are also important when you're determining Medicaid eligibility. There's basically two kinds of CHIP in Missouri. There's no-cost CHIP, and then there's CHIP with a premium. And the rules are different for both of them. I think the one thing that we always have to keep in mind when we're dealing with Medicaid is for every rule, and there are zillions of them. Is there a feedback on that? There are zillions of them, and for every rule, there's an exception. So never say no. We're an open door. We open a case and we explore the possibilities, because we surprise ourselves every day with who's eligible. Okay, now we're going to go into some examples. This is one of my favorite slides. This was one of my favorite activities as a child. Okay, let's talk about a single mom with a 3-year-old child. Now, in Missouri, we're talking about the biological mother or the adoptive mother. It's different when grandmother is involved or another relative in that. So you have to consider the relationships in the family. So if in this family, it's a single mother with a 3-year-old child, if her monthly income is $234 or less, she's going to be covered as well as her child. But say, she gets a better job and her income's $1,500 a month, the child's going to be covered under regular Medicaid, and the mother is not. And then say her income bumps up to $1,900, child's still covered in the no-cost CHIP program. The child has transitioned from non-CHIPed to CHIP, but the CHIP no-cost program, which is where most of the CHIP kids are. So that family, not a lot of change for that family if the mother's income increases. But say she gets a really good job and she has a monthly income of $3,800, she's at 294% of poverty. CHIP goes up to 300% of poverty. The child's going to be covered, but mom's not. Mom's not unless her income is down there under the 234. And, you know, this is the group that we're losing with Missouri not taking the expansion. Now, if the child has access to any kind of affordable insurance, and the affordability standards in Missouri are very generous, so, you know, if the child has access to affordable insurance, she's not going to be eligible at that CHIP premium level. She'll be eligible at the other levels, but not at that CHIP premium level, because they want them to have private insurance rather than Medicaid. But those guidelines are pretty low, so the affordability standard is usually not a problem for our clients. Okay, now we have the same single mom, and she is pregnant. Well, Medicaid for pregnant women is at 185% of poverty. So if you're considering the mom, you know, getting that job that was $1,900, she's still going to be eligible for Medicaid for pregnant women, you know, earning that $1,900 a month. But then if she got that really good job at $3,800 a month, she's not going to be eligible for pregnant women. But in this scenario, say her income is $3,000 a month, that's 184% of poverty. She's going to be eligible for Medicaid for pregnant women, and her child's going to be eligible under the CHIP premium program. But you have to consider what are the rules. Well, for Medicaid for pregnant women, it's not a family of two any longer, this mother and her child. She's carrying another child, so it's actually a family of three. The income guidelines for her are going to be based on a family of three. For the child, they're going to be based on a family of two. So, you know, that's part of the dilemma. And then I'm going to skip through, I just got my warning sign. So I'm going to skip through these families. You know, it's just the family dynamic changes and the coverage changes every time there's any kind of an income event or, you know, the mom becomes pregnant. So the persistent problems that we run into are with the application, confusing questions, missing information. There's a lot of supporting documentation, like in the premium program, you have to provide what your employer's insurance would cost, what private insurance would cost, those sorts of things. And then there are hopeful changes on the horizon, I hope. You know, I don't know how it all is going to change. I know how it is now. It took me 14 years to learn it, and I'm still learning. But the single streamlined application, I think that's going to be wonderful. We have a couple of different applications right now. And the no wrong door, you can get help anywhere. Electronic verification, all of that supporting documentation that has to be provided and that results in people losing their enrollment, that is going to hopefully be lessened. And then in the Affordable Care Act, there is also an emphasis on retention. In Missouri, thousands of children lose their coverage in and out and in and out because of glitches in that whole morass of the computer system. So there's an emphasis on retention, and you know, we're hoping that under the Affordable Care Act, kids are going to keep their coverage. Okay, thank you.
Before I introduce Kit to talk about enrollment in the marketplace, does anyone have any questions for our three panelists who have spoken thus far?
For Joanne, can you explain just a little bit more about what it means when it says, the picture says access to affordable private insurance? So if an employer offers it, but the mom would have to pay 100%, how do they just determine affordable?
And if you could sum up the question for the videotape, that would be great.
Oh, okay. The question was about affordable insurance. How is that determined? It is what it would cost, whether the insurance is affordable to the family to cover the child. Now, most employers, they do not allow you to cover your child and not yourself. So, that's another issue that came up a lot in the past, not so much anymore. But so the parent has to pay, like my former jobs, right now at Legal Services, I don't have to pay but a small portion of my monthly premium. But in former jobs, I had to pay 40% of my monthly premium. So a lot of the people that I worked with, I had a pretty good paying job and could pay that 40%, but, some of my coworkers, they were at the lower rung of the ladder, and they couldn't afford to cover themselves. But, so they look at what it would cost the family to cover both the parent and the child. And let me see if I have the affordability. Okay, so it's at the various levels of CHIP, like if you're in the first rung premium, second rung premium, third rung premium. So there, even at the third rung premium, the affordability is if it would cost more than $183 a month, it's not affordable. Now, I know our own Legal Services, which is pretty generous, you can't cover your family for $183 a month. So, so that the affordability standards are pretty good, but there still are some policies out there, and they don't have to be the best of policies. They can cover just the basics, physician and hospital, and its coverage. Yeah.
Additional questions? Actually, I'll come to you.
I think this is probably going to be a question that's hard to answer, but I'm curious whether when Primaris was working with Medicare Part D, can you extrapolate from that experience maybe how many times you're going to meet with someone before they make a decision to enroll? I mean, I think that I realize Part D is a different program, but I think that I'm trying to figure out how many touches you have to have with someone from the time that you educate them about the options to the time that they actually make a decision.
It's not uncommon for a person to come in and we would do a comparison for them. So we would go over the benefits, explain how the plans are, and then for them to take it home, look at it, discuss it with a family member, and then come back to enroll or to do it by themselves, have another family member enroll them. So, now that people have a little bit more experience, they can easily make that decision, maybe with the first visit. But if they're new or if they really have a lot of medications or have a lot more decisions to make, it could take 2 times. And, it also could take more than that. But the average for us is about 2 for Part D.
Okay. Grab this one and then one in the back.
I guess this is probably for Joanne. People at the low end of income often tend to be the least stable within their job. So can you talk a minute about changes of status? I am covered, I am not covered, I am covered, I lose my job and have COBRA, et cetera, waiting periods and so on.
Okay, any time there's a change in the family status, losing a job, that you report, the person is supposed to report that to the Family Support Division within 10 days. And then the Family Support Division redetermines eligibility. But going back to some of the scenarios and all that, usually when a person loses a job, they might be eligible for unemployment. So, you know, the unemployment, that's going to disqualify the parent. But say there's no income for the family, you definitely want to jump on that because you can get the parent covered, the parent's covered for 3 months, then they get transitional coverage for up to for 6 months, up to a year, and that sort of thing. But reporting it to the Family Support Division has been a problem for a lot of our clients because then they request some supporting documentation. It doesn't get there. There's a 10-day limit. Coverage is cut off, and that sort of thing. So those transitions are difficult, but it starts back with the agency that determined the eligibility in the first place, the Family Support Division. We've been told we should be very excited about their new computer program. Their current one is not serving families well. So I hope that answers your question. Probably as much as can. Okay, thanks.
Gonna get my exercise today.
I work with a lot of caregivers who have a new baby, and so once they get kicked off the 45-day Medicaid and they re-enroll, it seems like some of them are qualifying for full Medicaid, and then some of them at that point are qualifying just for well woman exams and OB care. And I'm wondering if Joanne can explain a little bit the requirements, eligibility-wise, what the difference is between the two groups and why some folks would get one and not the other, and that sort of thing.
Okay, Medicaid for pregnant women, most of you probably know that it's very specific to the date the child is born. The woman should be covered throughout her pregnancy if she's at 185% of poverty, and they can go back and cover from the beginning of the pregnancy a lot of times. So she's covered throughout her pregnancy and for 2 months following the month in which the baby is born. Baby is born today, she would be covered for September and October as well for her postpartum care. Now, after the postpartum coverage ends, and her infant is going to automatically be enrolled in Medicaid if she's on Medicaid for pregnant women, her infant is automatically going to be enrolled and covered for at least a year. No questions asked. Once a woman's on Medicaid for pregnant women, they can't stop it unless she moves out of the state. So after Medicaid for pregnant women, it all depends on whether the mother is eligible for one of these other programs. And it goes back to that scenario with the single mom with one child. If her income is at $234 or less, well, now she has 2 children, so it would bump up to, I think, $292 or whatever. But unless she is that poor, she is going to be eligible only for extended women's health services. And that only covers family planning and sexually transmitted disease. And it's very limited even in those programs. But it does provide a lot of birth control for women and some other services. But it's all income based once the baby is born and her postpartum period ends. Does that answer that?
What is the income guideline for just getting well woman care? Like, what is the poverty level?
Oh, there is no income guideline for that following Medicaid for pregnant women, except that you can't have insurance that covers that.
We'll take additional questions after we get to Kit. So I'm going to introduce Kit and let him take the mic.
Thanks. Good morning, everybody. I like to sort of walk around. It's sort of that inner rock star I've got in myself, you know. So I'm going to sort of walk around a little bit. They've got me in a box here, but I'm going to do my best. I'm going to have to go through this. I feel like, you think about, you turn up the speed on this, and you're going to go real fast, because I did a presentation that's really for a longer group, because I wanted it to be there on the website for people to refer to as they need. So a lot of this first part I'm going to go through really fast. You're welcome to read it later, but I want to make some points because I didn't want to assume that everybody was up on, like, for the marketplaces. Let me show of hands really quickly. What do you feel like you're pretty well versed in what the marketplace is and essentially what the goals are and how it works? Raise your hand. Okay, that's excellent. Okay, because I'm going to go through this really fast, but I'll be happy to take questions later, take questions afterward if you have some individual questions about it. But I'm going to go through the first part because I really want to get to the enrollment process. Okay? All right, what is ahead? Everybody, this is what we've been working up to for 3.5 years now, to getting people actually enrolled. Marketplaces are basically a form of, they operate a lot like something like Amazon.com. You create an account. Once you have an account, then you can start looking for a product. That product happens to be health insurance. Okay, states can design their own marketplaces. A lot of states have. Colorado, Minnesota, California, Oregon, Washington, New York. These are operating their own exchanges. Other states, such as Missouri, chose not to. So the federal government will operate the exchange. To the average consumer, there's no difference. There's some differences for small business. They lost out on some opportunities by having the federal government run it the first year. But for the average consumer, they won't notice any difference. Employers with employees up to 50 employees can enroll through the marketplace. It's called SHOP. The federal government loves acronyms. It stands for Small Business Health Options Program. I don't know how many people work to come up with that, but the SHOP is what it's called. It provides tremendous benefits for small business. If you look at the prices that are coming out in other states that have released their prices, California, in Los Angeles County, for instance, prices dropped 22 or 29%, depending on the rating area. New York, they fell about 50%. That's a little different because New York had a different kind of market that pushed up prices before. But in Oregon, they dropped 35% for small businesses. And the hint we have in Missouri was, I was on a panel with the president of Blue Cross of Kansas City, who said that he expects that, this is right after they filed their rates, which have not been made public yet, but he said that about 2/3 of their small business clients will see a decrease in rates. The other third will probably see somewhat of an increase, but two out of every 3 should see a decrease in rates. So it's a tremendous benefits for small business, particularly if they have a worker who has a heart attack or comes down with cancer, some significant illness. They will no longer be sort of held hostage to the experience that a small group has. They'll be rated based on everybody in the plan. Prices, and as you know, one of the big changes is that no longer can insurance companies refuse to cover you because of your health condition. Well, they also can't charge you a different price. Only 4 rating factors are allowed to be used. Number 1 is age. There can be rating bands. So older people can be charged more, but not more than 3 times as much as the youngest customers. Tobacco use. This is actually a protection for smokers. Smokers cannot be charged more than 50% more. Insurance company does not have to charge more, but they can charge up to 50% more than non-smokers. Location, if there's rating areas within the state, they can charge more in Springfield than they do in Columbia if the insurer can show that there's a difference in the cost. Family size, this is traditional. A family size, a family plan is going to cost more than an individual plan. That's traditional. No longer, as Stephanie said this morning, no longer will being a woman be considered a pre-existing condition. Right now, a 22-year-old woman often pays up to 50% more than a 22-year-old man if they're both healthy. Well, no more. those prices have to be the same. All plans will have to cover what are called the 10 essential health benefits. Right now, 5 out of 8 plans in the individual market don't cover maternity benefits. 1 out of 11 don't even cover prescription drugs. Well, no more, this is what this law was set up to do. One of the things is no more will a person buy an insurance plan and when they try to use it, find out that something obvious is not covered. Okay? These are the 10 essential health benefits that all plans have to cover. Marketing of policies, this is what the marketplace, sort of their basic rules and goals and duties that the marketplace has. There'll be a toll-free number for the plan to get information. That toll-free number is already out there. We'll get to that in a few minutes. A website, that's the main way people are going to sign up. Much more efficient, much easier to do because it's a dynamic application. The questions change according to your answers. But there is a paper alternative. If somebody just for some reason can't use a computer or can't find someone to help them, there is a paper alternative. Benefits are in a standardized format, so you can compare plans, basically right next to each other. No more hunting for the premium, like it's on page 7 on one policy and page 42 on another. You'll be able to compare things side by side. There will be a comparison tool on the website. The premium calculator will take into effect the affordability programs that give people discounted insurance based on their income. The calculator will take that into account so people can know right away what it's going to cost them every month out of pocket. There won't be any guessing. It'll also show the cost-sharing reductions. If you have income below 250% of the poverty level, you not only get a discount on the price through these tax credits, but you also get lower co-payments that are called for in the policy, lower deductibles, and in many cases, either a 2/3 or 1/2 reduction in the maximum out-of-pocket costs. Remember, what the president said when he signed this was that nobody should have to go broke because of a health care need. Well, that is what protects low-income people from going broke, is these lower out-of-pocket costs. The marketplace will also give a preliminary eligibility for Medicaid and the Children's Health Insurance Program. Final eligibility is still with the state, but a preliminary eligibility will be seen. And it'll review plans to make sure they're eligible, that they fit the requirements. We don't want any plans sneaking through that, for instance, don't have an adequate network. Okay, all the plans, and this is being done right now, being evaluated, all the plans have to have an adequate network of providers. They can't, one of the classic ways insurance companies would sort of choose to discriminate was if there's a main hospital that cares for disability patients, well, you just don't put that hospital in your network. Then you reduce the number of disabled people who are in your policies. That won't be allowed. They have to be, and it has to be a non-discriminatory provider network. Okay, enrollment operations, coverage, as I'm sure you know, but coverage begins January 1st. First enrollment begins October 1st. Enrollment period goes through March 31st. So remember, in many ways, this is a marathon, not a sprint. Okay, while all our focus is on October 1st, that's when it starts. We've got 6 months that first year to enroll everyone. Now, if they don't enroll by March 31st, they have to wait until the next enrollment period unless there's what's called a qualifying life event. They get married, and these are traditional in the insurance business. Get married, they have some other event. They can't just have, on April 1st, have a heart attack and decide, oh, well, I'm lying in the ambulance, I'm going to call up and enroll in insurance. Okay, that's not going to be allowed. All right. One section of the marketplace serves individuals. One serves small business. The one thing that I was saying, the big thing that small employers lost by the state not doing a state-based exchange was what's called employee choice. Employees were going to be able to, or in the state-based marketplaces, most of them allow employers to basically throw it open to their employees and say, look, I'm going to give you a standardized amount say $5,000, toward your insurance. You pick the plan you want, as generous as you want, as expensive as you want, or as low cost as you want. And employers, that was a really great benefit for employers. It was really popular in the state-based marketplaces. Unfortunately, in the federally run marketplaces, that option won't be available to next year. What they'll have, what small employers can do is just like they do it now. They pick one plan for their employees and say, this is the plan that'll cover my workers. So that's one of the things that they lost out on. Making insurance affordable. Affordability programs are very important. You know, it's the first name of the law, Affordable Care Act. Credits are available up to 400% of the poverty level. That's about $46,000 a year for an individual person, about $94,000 for a family of 4. IRS estimates the average tax credit was something more than $5,000 per policy. Really big benefit for family farmers and the self-employed who've always been on their own. Now they'll get some help as if they had an employer helping them pay for part of their insurance. That is a sea change in health insurance in our country. And another benefit for small employers is if they can't afford, especially a very small employer, let's say it's 10, 12, 20 employees, just can't afford insurance for their workers, there's no penalty for not providing insurance for any company that has fewer than 50 employees. So they can't afford it, they don't have to, but now their employees can go to the marketplace and get a discount as if they had an employer helping. Tremendous benefit in helping those employers keep workers, because they're always losing workers who say, you know, I can't, I like working here, I like the people, but I got to have benefits. Well, now they can, and they can stick with that small employer and grow along with it. Here's some charts, and I'm not going to go over these in detail because you can see them on the website later, but here's some charts about the whole law is based on, and frankly, it's a very conservative idea. Everybody has some skin in the game, and based on your income, you've got to contribute a certain amount toward the health insurance market, but you're not on your own. You'll get help doing it. So the third column from the left, the expected contribution. At low incomes, no one is expected to contribute more than 2% of their income. So roughly $14,000 a year, 120% of the poverty level, 2% of income. They will be able to get a very solid, what's called a silver level plan. So that's a good, solid, sort of typical good small employer plan. Covers on average 70% of the cost of an employee's or a person's medical costs. They can get that for $23 a month. They're expected to contribute something, $23 a month, but no more than that. The rest will be picked up by the tax credits the federal government pays to the insurer. As you move up the ladder to, let's say, the last line, $40,000, $215 a year, 350% of poverty level, they're expected to contribute up to 9.5% of their income toward health care. That'd be $318 a month. Since the average now is around $500 to $600 a month, depending on where you are, they're still getting a significant benefit. And I talked about those cost-sharing reductions. At the lower income levels, below 250%, there's a breakdown of the reduction in out-of-pocket costs. The maximum reduction in out-of-pocket costs for the 3 lowest bands there is 2/3. So if for their individual plan, if their maximum out-of-pocket cost next year will be $6,350, well, that will be reduced by 2/3. So their maximum out-of-pocket cost will just be a little over $2,000. Okay. Here's the same chart, but for a family of 4. As you can see, at 141% of the poverty level, 3.5% of their income is their expected contribution. So they should be able to get a plan for less than $100 a month. Covers everybody in the family. And remember that health insurance is much more valuable under the Affordable Care Act. You get free preventive services, kids get free vaccinations, the wife is eligible for free birth control. I mean, that will save, just those things will save that amount in premium. When you apply to for lower costs in the marketplace, you'll need to estimate your household income. These are the things you need to sort of get across to people. Most people can use, if they are familiar with the nomenclature, they know how their tax return looks. It's the bottom line on the first page. That's their adjustable gross income. For most people, that will be the number, and they'll have to estimate it for 2014. But if you're not familiar with that, you can add up these things: wages, salaries, tips, net income, unemployment, Social Security payments. All those count toward a person's household income. Okay? Other kinds of income also are included, but probably are not going to be significant for most of the people that we help. Rental income, interest, dividends, capital gains. Donald Trump, I don't expect, is going to be getting a discount. Although he may try, from what I've been reading. Anyway, beginning in 2014, individuals have to, most individuals, there's a few exceptions, but are required to have insurance or pay a penalty. That penalty starts out very modest, but by the second year starts to become a significant bite. The fee is the greater of, first year it's only $95 a person. It's per person in the household. And then children are counted as half. So it's pretty small, or 1% of income. So 1% of income is usually going to be higher than that. And technically, it's the amount that exceeds the tax filing threshold. Roughly, that's $10,000 a person for each adult. So $20,000 for a married couple that isn't counted in the calculation. By the third year, so by 2016, $700 a person, and they don't get anything for it. For many people that you're going to be helping, the penalty will exceed the cost of their share of the premium. That's something that really, I think, needs to be emphasized to people. That premium will be, or that penalty will be more than the premium they would pay with the discount that the government provides. Okay? Consumer assistance. This has been said, this is actually words from the law. There shall be no wrong door to enrollment. So there's going to be lots and lots of different groups that are expected to sort of help people sign up. Okay? This is the key website, healthcare.gov. In Missouri, because it's a federally run marketplace, this is where people will go to sign up, to get information, to look at plans. Okay? Minnesota, for instance, they have something called M-Insure. M-In is their thing, but M-Insure, they have their own. Colorado, it has their own. Kentucky, it has its own website. But if they happen to go to healthcare.gov, first question is, what state are you in? If you're in one of those states, it'll direct you to the website where you should be. You put in Missouri, you stay on that website. You can sign up, and I encourage everybody to do this. You can go there now and sign up for email or text updates. You'll get these email updates automatically. And it's really a great way to keep up on the changes and the new regulations that are coming out. Healthcare.gov was redesigned in June to emphasize enrollment. And it's designed to evolve as we go on. It went live in June. It's going to be redesigned again at the end of next month to more aggressively facilitate the enrollment. So everything will be right there on the front page. You can go there now and create an account. I did this the other day, and it's not unlike going to Amazon.com and creating your first account. There's some extra questions. You have to put in some security answers and things like that. But it really is simple, and people, I think, frankly, the majority of people should be able to do it easily by themselves, but there are always going to be people who need some help or just need some reassurance, because anytime you try something new, it's a little tricky. There's a great feature on it, and I've got it in red there. There's web chat availability. You can put in questions, and I've done it 4 or 5 times. I've never had to wait more than about 30 seconds to get a response back. Not the answer, but at least a response. Okay, what's your question? What do you, maybe a question about the question to clarify it. And I mean, it's an amazing, effective way to get information is to use that. Okay. The call center was launched in June. 318-2596. They do a great job. I've called up with some real mind-bender questions, and they eventually have gotten back to me. In both cases, it was, well, that hasn't been decided yet. So, but at least I got an answer. You know, that was reassuring that I got an answer. And I also tested it just with some fairly basic questions, and I got the right answer back. I was impressed. You know, you read about these message centers and that they give you the wrong information 3/4 of the time. Well, at least so far in my very limited testing, I've been impressed with the job they've done. They can help with health insurance and how it works. Okay. Premium assistance, steps to take now to get ready, and after October 1st, they will actually walk people through the application and help them make a plan selection. So this is always an option, if you're helping somebody, for you to call. Okay. Assistance is available 24/7 in English and Spanish. Help is also available in 150 other languages. It won't be immediate, but they will hook you up with a language line. In Bosnian, you know, in St. Louis, huge Bosnian population. If you need that, it'll be there. Vietnamese, Chinese, you know, Kansas City has a very large Vietnamese population. It'll be available in people's own language. Small Business Health Options Program. In August, they launched a call center for employers. So if you're dealing with any employers, you can refer them to this. It has information about the tax credit that's available if very small employers with fewer than 25 employees need insurance or are trying to find insurance for their workers, that they can find out information about that. There's new, more competitive pricing. And I want to point out this website here. The SBA has some really very good fact sheets and training materials on their website. And depending on business's location, size, and whether they offer insurance now. Okay, how the marketplace works. It really is fairly simple. Now the plan selection process, you know, is going to be complicated because it's very individualized. But the process really is simple. You sign up, create an account. Once you have an account, you fill out an online application. You start comparing plans. As I talked about before, there's a comparison tool on the website, and then you enroll. I want to emphasize that people, for coverage to start January 1st, they have to enroll by December 15th, okay? Because there's always, you know, you have to give the insurance company time to process this. If you sign up in the last half of the month, coverage won't start until the first of the following month after that. So if you sign up December 20th, insurance coverage won't start till February 1st. But if you do it in the first half of the month, you'll have coverage the first of the following month. The application, as I said, the application really is pretty cool. I don't want to sound too geeky here, but it really is cool. If you put in information, you put in your income amount, the questions change depending on, like if your income is very modest, the question will change to ask more questions to say, oh, perhaps you're eligible for Medicaid, and we'll steer you toward Medicaid. If you have been in the military, it may steer you to give you a message saying you should look into the Veterans Administration benefits because you might qualify. So it steers people based on their answers toward the questions, the information they need. Okay. Here's a website where the paper applications are available to look at. And the Enroll America has on their website a couple of video demonstrations. And I don't know why, but the demonstration they chose was for a family of 3 in Missouri and a single man in Arizona. I guess those were the 2 least offensive states or something. But for whatever reason, those demonstrations really are pretty good, and they're fairly short. I think the Missouri one is about 17 minutes, because obviously it's more complicated because you've got kids and there's a family. And then the one for the single man in Arizona, I think, is about 8 or 9 minutes. So those are good to look at. Finding the right plan. Once an account is created, the website offers a series of helps. Again, the calculator calculates the premiums, the co-payments, the deductibles, maximum out-of-pocket costs. It gives you that information. There's a filtering option that basically puts the kind of plans you're looking for at the top. So you don't have to it's not just a jumble. There's an algorithm that puts the plans in the order that the algorithm predicts you will be needing, okay? To set up an account, here's just some quick things. I just walk you through it. You fill in the form, click next, choose a sign-on name, password, confirm your email address. You get an email address back, or a message back. You click on it, and it goes to, it confirms your account, and you have created the account. In-person assistance, navigators. I gotta go through this really fast here. Navigators were named just 2 weeks ago. Key groups the navigators will work with are low-income groups, non-English speaking populations, people with disabilities, workers between jobs. Missouri received $1.8 million. Primaris was the biggest in our region, got a little over $1 million. Missouri Alliance for Area Agencies on Aging got about $750,000. Application counselors, which I encourage all of you to become, they received similar, but at first it was going to be exactly the same training, but now they've made it less extensive training than the navigators. Same training, but just less extensive. They have to pass a similar test, but again, it's less extensive because the training is less extensive. Basically, the marketplace, you have to work or volunteer for an agency that has been designated by the marketplace. And they did this as a security precaution to make sure that some agency is responsible for the people, the volunteers and staff who were doing this work. The counselors must show applicants all insurance options available. And to ensure unbiased advice, no money can come directly or indirectly from a health insurer. To apply to be designated as an application counselor, here's the website, marketplace.cms.gov. If you go on that, there's a link that says Get Training, and you click on that. Agencies designated as application counselors will be listed under Find Local Help. They will be on the website. And questions about becoming a certified application counselor, there is an email address where you can ask questions. Licensed insurance brokers, these are sort of the Darth Vaders of the process, but they're going to be a very important part of the process. They are not required to show people all insurance options. They work for insurance companies, particular insurance companies, and that's it. So they are not required. And let me see if there's one other thing I wanted to put. Oh, state requirements. State requirements have there's a quirk because here in the state of Missouri, insurance agents got through a piece of legislation that required an additional form of training. Another test. There's no training, but the assumption is you'll go through the federal training. That will give you enough information to pass the state test. Okay. And you have to take care of the security. Security of personal information is required. Some of the critics of the law are predicting that there'll be all these scam artists out there trying to steal from very, very poor people. Apparently these are not real smart crooks, they're predicting. But in any event, there's a lot of concern about the security of personal information, so there's a lot of requirements about that. To screen staff and make sure that just not anybody is being allowed to do this. And let me see. I've got key marketplace dates. So far, we are hitting the deadlines. Things are falling into place as they were predicted. And coming up, health plans and prices should be available next month. In some states, they might not be available till October 1st. I don't see that as a big problem because, frankly, you can't do anything with the information until October 1st anyway. But everybody is really antsy about seeing what the prices and what the health plans are going to be. We will see them. And again, enrollment opens on October, but it ends on March 31st. Very important to remember that. Here's a list of potential or potential websites that could offer different information. Sign up for email updates, learn about different types of health insurance coverage, setting your budget. Very important to get people to realize they're going to have to pay this every month. Steps to take now: gather information, have people gather information about their household income. There won't be, as long as they've had a regular job, this should be streamlined because it'll all be done electronically. They'll only be asked for additional information if the information they provide does not match the electronic information that's available from the IRS and from the State Employment Division. So there should be a minimum amount of documentation that people have to provide, okay? And I'm going to, should I take questions now or?
Take 2 quick questions.
Okay. Oh man, you're gonna make me choose? Okay, I'm gonna take both.
If somebody is enrolled in Missouri for health coverage, and then they move to Colorado, let's say, is there a period that Missouri will cover while they're in Colorado until they get enrolled in that system?
Okay, the question is, if you move to another state, is there a period? Well, the answer is that they will have to enroll. They're eligible to enroll outside the enrollment period if they've had coverage for whatever reason. If they've lost their job, they had coverage, but now they don't, they can enroll outside the enrollment period. The only time you're prohibited is if you've gone more than 60 days, then you have to wait till the next enrollment period. If you're changing states, your coverage doesn't end on the day you cross the state line. The coverage usually goes to the end of the month that you've notified the insurer. You will then have to sign up. There shouldn't be a break. As long as you sign up right away in your new location, there shouldn't be a break in coverage. But you do have to go through the state's marketplace where you're living.
But you have to notify your previous coverage.
Sure. Yeah, yes, you have to notify your previous insurer. Oh, you're next.
I had a question. You talked about the application being dynamic and changing where it is. For states that have chosen not to expand Medicaid, for the folks that fall in that income bracket between what Missouri now covers, Medicaid, vision,
100%.
How will the application or how will that process happen?
Okay, they know, the federal government knows, and the marketplace knows that Missouri did not expand the Medicaid. So what I want to encourage everybody to do, right now, if you're, the law foresaw expanding Medicaid to 133% of the poverty level. There is, for people between 100 and 133%, they can still sign up. Medicaid is not available to them in Missouri, but they can still sign up for the discounts and these tax credits from 100 to 133, and they get huge discounts. It won't be Medicaid, but it'll be close to it. They will only have a very small amount to pay in premiums. So they are still within the program. The real gap is from about 20% of poverty level to 100. Ironically, they don't make enough money to be eligible for the discounts. So what I am encouraging people to do is sign them up for Medicaid anyway. Sign them up and let them get turned down. Because, as Joanne was saying, it's amazing the different kinds of exceptions that they may apply to them. So have them enroll in it, attempt to enroll in it anyway, and let the state turn them down. At that point, they've got to, there's the traditional safety net outlets, community health centers, and things like that. Unfortunately, the state chose to leave those people uncovered.